As you know, non-cardiac surgery in severe aortic stenosis patients has traditionally been associated with high perioperative mortality rates. However, recent advances in anesthetic and surgical techniques have been associated with improved outcomes in such patients. Hello, my name is Alan Lewis, and I'm a cardiologist in the Department of Cardiovascular Medicine at Mayo Clinic. Today, I'm going to discuss our article entitled Impact of Aortic Valve Replacement for Severe Aortic Stenosis on Perioperative Outcomes Following Major Non-Cardiac Surgery, which is to be published in this month's issue of Mayo Clinic Proceedings. Contemporary studies, including one from our group, have investigated outcomes after non-cardiac surgery and found that patients with severe aortic stenosis have comparable 30-day mortality rates to matched controls, albeit with some increases in major adverse cardiac events. However, no studies to date have compared the incidence of death or major adverse cardiac events in severe aortic stenosis patients undergoing non-cardiac surgery with and without aortic valve replacement prior to their non-cardiac surgery. In our study, we retrospectively assessed outcomes including death and major adverse cardiovascular events amongst all patients with severe aortic stenosis who underwent non-emergent, elevated risk non-cardiac surgery at Mayo Clinic. Elevated risk non-cardiac surgery was defined according to the current American College of Cardiology and American Heart Association guidelines, and included those patients who had surgeries which may previously have been described as being intermediate or high risk non-cardiac surgery. We categorized severe aortic stenosis patients into those who underwent surgical aortic valve replacement before non-cardiac surgery and those who did not undergo aortic valve replacement prior to their non-cardiac surgery. The surgical aortic valve replacement group included both patients who underwent aortic valve surgery in preparation for their non-cardiac surgery, as well as those who underwent surgical aortic valve replacement within 12 months prior to non-cardiac surgery. In total, we evaluated 491 severe aortic stenosis patients, including 203 who underwent aortic valve replacement prior to their non-cardiac surgery, and 288 patients who did not undergo aortic valve replacement prior to non-cardiac surgery. We found that the incidence of major adverse cardiac events was significantly lower in the aortic valve replacement group, primarily due to a reduction in the incidence of new or worsening heart failure when compared with those patients who did not receive preceding aortic valve replacement. It was interesting to note that at 30 days, there were no significant differences seen between both groups in the incidence of death, myocardial infarction, ventricular arrhythmias, or stroke. However, symptomatic patients who did not undergo aortic valve replacement had the worst outcomes overall, including an increased 30-day mortality and major adverse cardiac event rates at 30 days when compared to those patients who had aortic valve replacement or those who were asymptomatic and did not undergo aortic valve replacement. Patients in the study were also followed up in the long term with a median 4.2-year follow-up, and we saw that the overall mortality was significantly worse in severe aortic stenosis patients who did not undergo aortic valve replacement prior to non-cardiac surgery, but the worst outcomes seen in the symptomatic patient group. The findings of our study suggest that aortic valve replacement for severe aortic stenosis prior to elevated risk non-cardiac surgery is associated with a markedly lower incidence of perioperative new or worsening heart failure when compared with non-cardiac surgery without prior aortic valve replacement. This benefit was greatest among symptomatic patients in whom non-cardiac surgery is associated with a lower incidence of heart failure and lower 30-day mortality. In asymptomatic patients, aortic valve replacement before non-cardiac surgery was associated with a lower incidence of heart failure without a difference in 30-day mortality. Long-term mortality, however, was worst among symptomatic and asymptomatic patients treated medically without surgical aortic valve replacement. Hence, the findings of our study suggest that in patients undergoing non-emergency, non-urgent, elevated risk non-cardiac surgery, aortic valve replacement should ideally be performed before non-cardiac surgery to minimize the risk of postoperative heart failure and to decrease the long-term risk of death. However, it is reasonable under certain circumstances to consider performing elevated risk non-cardiac surgery without prior aortic valve replacement if close anesthetic monitoring is used, particularly in asymptomatic patients. This would include time-sensitive procedures in which aortic valve replacement would result in inappropriate delays in non-cardiac surgery, such as in patients with certain types of cancers, or if patients are not suitable candidates for surgical aortic valve replacement. Thank you very much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.